Hello, everybody, and welcome back to the channel. Today, we are breaking down one of the most critical topics, that is spinal trauma from Rosen's Book of Emergency Medicine. Let's get started. So, injuries to the spine occurs particularly in a patient that has got multi-system trauma, but when it is missed, it can lead to significant morbidity and mortality. According to Rosen's Book of Emergency Medicine, the injuries can be classified into different types based on the mechanism of the injury, namely flexion, shear, flexion rotation, extension, and vertical compression. Flexion is the most common type of mechanism, and it normally happens when the head and neck gets abnormally flexed. So think of a person in a car collision whose head and neck goes forward because of the force. So let's talk about the flexion injuries. We have got flexion teardrop fracture, which is a highly unstable fracture, and it takes a lot of force for flexion teardrop to happen. Here's flexion teardrop. You can see that tiny triangular piece separating from the anterior side of the vertebra. Then we have got clay shoveler fracture that got its name after it was mostly observed in clay miners, where the head and neck would have a significant flexion force when a clay miner is tossing a heavy slab of clay. Now it is considered a stable fracture, and this is what it looks like. So we can see it in the transverse process. Wedge fracture is a stable sort of a fracture that generally occurs in elder osteoporotic people. This is what it looks like on imaging. Bilateral facet dislocation, just like flexion teardrop, requires a lot of force for the anterior structures to get disrupted, and it is also an extremely unstable sort of a fracture. We can see it over here in this picture. And finally, chance fracture that occurs with a combination of distraction and flexion forces, but it is usually stable. So this is what it looks like, the fracture extending to the transverse process. The next category is shear trauma, and as for shear injury, imagine spine as a stack of buildings. So when two blocks in a stack are violently forced to slide or shift horizontally, it can cause injury like odontoid fracture, where the peg gets broken off from the body of C2. Itself, it can be of three different types: type 1, type 2, and type 3. Type 1 is an avulsion of the tip fracture. Type 2 is from the base of the odontoid fracture, and type 3 is when it extends into the vertebral body. Now, type 1 is a stable sort of a fracture. Type 2 and 3 are unstable, but it is type 2 that we are most worried of because it has the highest rate of non-union and hence poor prognosis. So this is what it looks like. I want you to write down in the comment box what type of odontoid fracture do you think that this is. Flexion rotation injury occurs when flexion gets combined with rotation, as the name suggests, like in a rollover or side impact collision, and it produces facet dislocation, usually unilateral. But unlike bilateral facet dislocation, which is quite unstable, unilateral one is very stable. So here we can see the unilateral facet dislocation of C5-C6. Extension injury occurs when the neck is thrown backwards, like in a rear end collision, and it can cause injuries like hangman fracture, posterior neural arch fracture, extension teardrop fracture. Now, out of these two, it's important for you to know about hangman fracture and extension teardrop fracture. Hangman fracture is a fracture of C2, very unstable fracture, and is basically a break in the back part of the atlas. So this is what it looks like. Extension teardrop fracture, also like flexion teardrop fracture, is a very unstable fracture, particularly in extension. This is what it looks like. Jefferson fracture occurs due to vertical compression. Basically, when the force gets traveled down the head, neck, and spine. So, for example, falling from a height and landing on feet or landing directly on the head. Jefferson fracture is a fracture of C1, very, very unstable as well. And this is what it looks like. As always, for all these patients, ATLS approach takes precedence. So, doing our ABCs applies, but it also starts with an early C collar. It is very important that we maintain inline stabilization during any airway management in these patients. Use video laryngoscopy if possible to minimize any movement and avoid hypoxia and hypotension, because then it can also impact their brain and spinal cord. Once the patient gets stabilized, it's important to perform a very focused neuro examination covering their motor, sensory, and reflex functions. Now, part of doing the motor neuro and sensory examination is to understand the concept of myotomes, dermatomes, and the reflexes. So, here's a big table covering all the motor activity from C4 to S4, reflexes, and sensory. I recommend watching videos where they explain how to remember motor and sensory examination via dances to be a very effective way to remember, because ultimately picking on these fine details means identifying neurological injury in these subset of patients. Don't skip doing upper rectal examination and to check for voluntary anal contractions. They're very essential for identification of emergent causes. As for indications for imaging, there are certain decision making rules. So we have nexus criteria which can be remembered with this mnemonic called SPINE. S for spinal midline tenderness, P for any painful or distracting injury, I for intoxication, N for neurologic deficit, and E for encephalopathy or altered mental status. Now, if all of this is negative and patient is pain free while moving their neck, they are cleared from a C spine perspective. However, recent literature has found that nexus has got low specificity, and hence what should be instead used is the Canadian C spine rule. In terms of the choice of imaging, we have X-rays. In today's context, it is rarely used, but it can be used if the patient is too unstable to be taken to CT. And remember, there's always low risk of radiation with X-ray. With CT, it is obviously our imaging of choice. It has got higher sensitivity than MRI for fractures and dislocation, but exposes the patient to significant skin and thyroid radiation. Finally, we've got MRI, and this is very good for any soft tissue injuries that may be missed on CT, but it may not be very feasible to perform an MRI in the emergency department. Speaking of soft tissue injury, we have certain patterns of injury in the spinal cord itself that we need to be aware of. Spinal cord injuries can either be complete or incomplete, and incomplete spinal cord are further categorized into different syndromes based on the area of the injury. We have central cord syndrome, which happens because of neck hyperextension, mostly in the elderly population. We will see that their upper limb will be more affected than their lower limb, and they will have a loss of pain and temperature. Now, this is a hemisection of the spinal cord. So, if we were to draw the area affected, roughly it would be around here. Okay. So obviously there is spinothalamic cord involved and there is the motor cord involved. If you look at this hemisection of the spinal cord, and if we draw where central cord affects, so it's mostly in this area, which will involve the spinothalamic as well as the pyramidal tract. Next, we have anterior cord syndrome, which is the opposite of central cord in terms of the mechanism of injury. So there is neck hyperflexion in these cases. They come also with motor paralysis this time and loss of pain and temperature. And if I draw it on the spinal cord, it's going to appear like this. Again, our pyramidal tract and our pain and temperature tract is involved. Finally, we have brown saccade, which is basically the hemisection of the cord. So, full half of the cord is involved. Now, this is the one where we will see ipsilateral motor position and vibration being affected, and contralateral pain and temperature be affected. This is the one where which carries the best prognosis out of the all three cord syndromes. While we are discussing spinal cord injury, it is also important to differentiate between spinal and neurogenic shock. Some people use this interchangeably, but that is not accurate. Spinal shock is basically loss of neurologic and autonomic tone below the level of acute spinal cord lesion. And generally, if a patient is having spinal shock, one of the ways that we say that the spinal shock has ended is when their bulbocavernous reflex comes back. Neurogenic shock, on the other hand, is loss of vasomotor function plus the loss of reflex tachycardia. So, what they say about low blood pressure and low heart rate in a patient together, you can't rule in neurogenic shock in a multi-system trauma patient unless and until you've excluded other causes of hypotension. And if a patient has neurogenic hypotension or shock, then it is managed like any other hypotension with some initial fluids and then vasopressors. This brings us to the end of today's topic.